Uh, Good evening once again. Am I audible?
Yes, sir.
Okay. Mm, so, in continuation of trauma, upper limb, we have divided in parts.
Yes, sir.
So, this will be part 3. Okay. Uh, so, for those people who have joined only from this class, you can go through the videos. Given occasion, sometime we can always discuss. In continuation of the trauma upper limb part 3, we will start. Okay. So myositis ossificans. What is myositis ossificans? You should know one thing. The word itself is a
Must.
misnomer.
Yes.
Word is a misnomer. 1 minute. Pen is not working. One second, Roshan. I am trying to my write something on this.
So this one option is there, sir. Hide. You can first hide.
Yeah, I know. But my generally that pen is not working. Every time I used to use this pen, you remember?
Sir.
So it will be easy for you people to understand. Okay, some problem is there. Okay. Okay, anyway, I think there's a problem. Okay, Roshan. So myositis ossificans is basically it is also called as heterotopic ossification. It would have been easy for me if I was using a pen. Heterotopic ossification means ossification anywhere else other than in the bones. Okay. Heterotopic ossification is also called as myositis ossificans. But myositis ossificans is by itself. Am I audible, Roshan?
Yes, sir.
Okay. Myositis ossificans itself is a misnomer. Why? Because there is no inflammation of the muscle. It is not inflammation of the muscle. It is ossification or in the inside the muscle. So most important thing what you should understand is it is most common in elbow and hip, most commonly seen in elbow and hip. To be precise, it is around the elbow for children, and for the adults it is hip. So most commonly myositis ossificans is always associated with the history of trauma and massage. Please remember this.
Yes, sir.
Patient brought to you with a history of trauma, not necessarily a fracture or dislocation, but they will come with history of trauma and associated with massage by a traditional bone setter. These two things are very inseparable part of myositis ossificans patient history. So in children it is elbow, in adults it is hip, most commonly following a surgery around the hip. So what is important again is myositis ossificans is a self-limiting disease.
Sir.
And most importantly, there is a because of the trauma, there is a ossification or calcification in the muscle. Most commonly, it is seen in anterior part of the elbow. See, here you can see these are abnormal ossifications. Here you can see this is abnormal ossification. Here you can see abnormal ossifications. And one more thing you please remember, what happens, hello? See what happens, this is abnormal site ossification, but hello, ಏನತ್ತೆ ಇಲ್ಲ wrong ಹೇಳು. See, what is important is again, if you are not trained in seeing such kind of radiograph, if you are not seeing such radiograph, what happens? So you will mistake this for a bone tumor. You will mistake this for a bone tumor. Understand?
Yes, sir.
One, you please understand, all the bones are normal here. There is no breach in the normal bony architecture. Look at this. There is a normal humerus lower end, ulna, radial head, everything is normal. So the bones or normal skeletal architecture is not disturbed. So whatever abnormal bone you see is not destroying any part of the bone. So this is one important thing what you should understand. If there is a radiograph given nowadays in image based question, such radiographs are given, you will see bone is not destroyed, and the whatever ossification or abnormal bone you see is seen in the soft tissue. Okay. One more important thing is, as I mentioned, in histopathology, you have to differentiate between myositis ossificans and osteosarcoma. Okay, in osteosarcoma, there is bone formation in the center. Myositis ossificans, there is a mature bones formation in the periphery. You have to remember this. And second is, see, if you are seeing such X-ray, you can always get confused some osteosarcoma like this. And see,
Yes.
what is important is, this is not a periosteal reaction. This is not a periosteal reaction. There is a gap here. There is a gap between the abnormal bony shadow or ossification shadow and a normal cortex. There is a gap here, clear cut gap. Yeah, of course, here you see this. Don't confuse this for a osteosarcoma. This is not fitting into any kind of periosteal reaction. Look at this. This is forming a bone bridge from acetabulum to greater trochanter or myositis ossificans. So what is myositis ossificans? Generally, history of trauma is there, massage is there.
Yes,
So
sir.
how do they present? They present with pain, severe pain. It is not related to the trauma. And second is limitation of the movement. You are not able to have a painless movement. There is a painful restriction of movements of the joint. Okay.
Yes, sir.
More importantly is, so how do you treat? It is a self-limiting design, self-limiting entity. It is a self-limiting entity. Please remember this. So what you do in acute presentation is, treatment is by giving rest. How do you give rest to the part? In upper limb, you give a collar and cuff sling. In lower limb, you give a bed rest. So in 2 to 3 weeks, avoid movement. Any passive, so whenever they come with painful range of restriction of the movement, your tendency is try to move to achieve the movement of the joint, but that is wrong. You give rest to the part. If you give rest to the part, the myositis ossificans is a self-limiting entity. So once this becomes a mature bone, usually it takes 2 to 3 weeks to appear on the radiograph. So what is the treatment? Treatment is rest to the part in acute stage. In chronic stage, or once there is a maturation of the myositis ossificans, the excision is the only treatment. Surgical excision of the bone. Surgical excision of the myositis ossificans, new bone. Because if you don't excise, there is a limitation or a bony block in the movement of the joint. So this is when it comes to uh, myositis ossificans with respect to trauma. But look at this picture. This picture, especially whenever there is a patient with a head injury. Myositis ossificans also is seen in patient with a head injury or any neurological disorder. See, again, there is a different type of heterotopic ossification. Myositis ossificans, tumor calcinosis, myositis ossificans progressiva. There are different entities. But please remember, myositis ossificans without history of trauma also can be seen in neurological disorder, like patient is bedridden with a head injury, Guillain-Barré syndrome, where prolonged bed rest there is a ossification in soft tissues. So in this hypoxic brain injury, so in this secondary to neurological disorder, where you are expecting a myositis ossificans, you do prophylactic irradiation, and the treatment is prophylactic irradiation. Second is give indomethacin. You can give indomethacin. You
Yes,
can
sir.
also give bisphosphonates. Please don't get confused. This is heterotopic ossificans, especially in following a patient in head injury or any surgery around the hip, only in some less than 10% of the patients. This is heterotopic ossification. This is one important slide I wanted to show. You see, what is this? There is bone formation everywhere. There is a
Yes,
normal bone here. There is a bone formation in the soft tissue. Look at this. It doesn't look like because of any injury to say, it is not because of the injury to the elbow, it is not because of injury to the knee. It looks everywhere. Everywhere there is a ossification of soft tissue. So this is a classical radiograph of myositis ossificans progressiva. You remember this picture whenever you encounter with the word myositis ossificans progressiva. Briefly, some important characteristics of myositis ossificans progressiva is it is a pathogenic mechanism because of defective regulation of induction of endochondral ossification. Please remember this. Normal endochondral ossification is there, but the regulation is altered. Defective regulation of endochondral ossification. It is a congenital disorder. It is a autosomal dominant disorder. Most commonly is seen in first decade of the life. Starts with a nodule in the back around the neck. And what is the progress, how it progresses is it starts in the axial skeleton, then spreads to the appendicular skeleton. It starts in proximal part of the body, then spreads to the distal part of the body. Right? Please remember, it starts in the axial skeleton, then to appendicular skeleton. Axial skeleton is spine, vertebral column. Appendicular is upper and lower limbs. Okay?
Yes, sir. Yes, sir.
And it starts from proximal to distal region. Most importantly is it involves almost all the skeletal muscles, but typically diaphragm, extraocular muscles of the eye, and smooth muscles are spared. Please remember this. In myositis ossificans, extraocular muscles and diaphragm muscle is spared. And of course, smooth muscles are always spared. It is a congenital skeletal deformity because of autosomal dominant disorder. And there is a premature death generally because of respiratory insufficiency. So all of the following are features of myositis ossificans, except quick.
It matures from inside out, sir.
Yes,
Outside in.
yes. Massage is always associated, commonly occurs around the elbow, and most can be traumatic. Don't confuse this. This is very, very important.
Osteosarcoma.
Yes. So don't try to remember both. You remember only myositis ossificans where it matures from outside in and it opposite is in osteosarcoma. You try and remember only one entity because the other one is the opposite of this. Myositis ossificans maturation is outside first, osteosarcoma inside first. Treatment of acute myositis ossificans. Active mobilization.
Immobilization.
Huh?
Immobilization, sir.
Yes, it is immobilization. As I said, it is immobilization. So next we'll go to something called as pulled
Pulled elbow.
elbow. Pulled elbow. You please remember, pulled elbow is also called as nursemaid's elbow. Nursemaid's elbow. Okay.
Yes, sir.
Roshan, can you tell me what is housemaid's knee?
Yes, sir. It's means when they are cleaning the house, the petal is completely touch with the ground, sir.
Correct. So what? So what happens?
Uh,
There
means
are there are
the
many bursa around the knee.
yes,
If
sir.
the bursitis of any particular bursa is named by, there are two things: housemaid's knee and clergyman's knee. Okay, please remember this. There are many pre-patellar bursa and infrapatellar bursa. They are separate. So what
Yes.
happens in clergyman's is what? He is a church priest. So how do they kneel? They kneel with the knee in 90 degrees. But in housemaid, the knee is bent more than 120 degrees. So when the knee is touching the ground for every prayer on Sunday's prayer or every day, so the infrapatella bursa goes for an inflammation. That is called as clergyman's knee. But in a housemaid's knee, where the housemaid works on the floor with the knee completely bending, the pre-patella, remember the bursa in front of the patella is different, bursa in below the patella is different. The patella in front of the bursa in front of the patella is inflamed. That is housemaid's knee. Okay, will not deviate. Pulled elbow, also called as nursemaid's elbow. So what happens? It is a subluxation of the radial head. It is a subluxation of the radial head out of the annular ligament. How it happens? You generally see that children below 1 year or 2 years, you hold them with the hand and revolve around, or both the parents lift the child with holding the wrist. So what happens? The radial head is subluxated out of the annular ligament. So the child is brought with sudden onset and inability to move the elbow. The child doesn't allow you to touch the elbow. The child doesn't move the elbow. But most of the parents or the ayah who is taking care of the children, they do not tell you the history because they are scared that they have caused some injury to the patient. But you see, there is painful restriction of the elbow, both pronation, supination, and movement. The child doesn't allow you to touch. So it is a very simple entity, subluxation of the radial head, called also called as a pulled elbow. The forearm is held in pronation. So what is the treatment? You can see here. This is how the child comes with. Of course, this looks an elderly, older child is generally around less than 2 years. So they come with the elbow flexed or extended, but forearm pronated. So what you do, hold the arm, suddenly you supinate the elbow, supinate the forearm, and flex the elbow. You put a sling around the neck of the patient, collar and it becomes stable. Pulled elbow is a benign entity. Treatment is on outpatient basis without any much of difficulty. You don't have to use any anesthesia or anything. It's also called as nursemaid's knee, nursemaid's elbow. So what is not true about pulled elbow? Occurs due to sudden axial pull in the extended elbow. Forearm is held in pronation and extension, most commonly between 2 and 5 years. Treatment is quick pronation and extension.
Treatment is quick supination and
Flexion.
uh, flexion, sir.
Very good. So pulled elbow means
Subluxation head of the radius.
yes, very good. There's nothing much to discuss on this. So we'll go to radial head fracture and olecranon fracture. There's nothing too much in detail required. Radial head fracture is more common in adults. Radial neck fracture is common in children. There are three types. These are Mason's classification. Don't try to remember. If possible, you remember. It is three types. Radial head classification is also called as Mason's classification. So olecranon, few important things about olecranon fracture I will tell you. So olecranon fracture, you please remember, it is a avulsion fracture. You compare the olecranon fracture with the patella fracture, where here strong triceps is attached to the olecranon, then strong quadriceps is attached to the patella. So what is the treatment in avulsion fracture? Always remember, it is tension band wiring. It is tension band wiring. So where all you do tension band wiring is olecranon fracture, patella fracture, greater tuberosity avulsion fracture in the shoulder, and in medial malleolus fracture. Okay, just out of the interest, I am explaining about the other sides of tension band. But please remember, olecranon fracture is avulsion fracture where the treatment is tension band wiring. Tension band wiring is figure of 8 with 2 ky. So excision of the radial head in a child should not be done. Read it. It produces instability of the elbow. Secondary osteoarthritis of the elbow causes secondary subluxation of the inferior radial nerve joint, causes myositis. Roshan. Anybody? Students, please don't mind. I keep calling Roshan because I am familiar with his name and he's been there with us for a long time. Okay, others can also answer. You need not, I would be appreciating if you can answer. Others can answer. Anybody for that matter. Yes, what is the answer?
Sir, it produces instability of elbow.
No. Elbow is humero-ulnar joint. Please remember this. Elbow is mainly elbow joint is between humerus and ulna. Okay. Now we are talking of radius. So
Sir.
certainly you are talking of a excision of radial head in a child. Remember that it is a growing bone. Okay. So
Yes,
we
sir.
will go by deletion or ruling out. It causes myositis ossificans, maybe, may not. Secondary osteoarthritis, definitely not because it involves in a superior radial nerve joint. It is a part of a superior radial nerve joint. Instability of the elbow, certainly not if the coronoid process and olecranon is intact. It will not cause any instability. Look at this. Secondary subluxation of inferior radial nerve joint. What
Yes, sir.
happens if you excise the radial head, which is still growing? What happens? It is a non-growing end of the radial head. So, ulna grows longer, radial will stop growing. So, there is a discrepancy between the radial and ulnar length. So, radius and ulna form two joints, three joints rather. Superior radial nerve joint, inferior radial nerve joint, and middle one is
Middle one.
intraosseous membrane.
Process one.
Okay, so there is a differential growth in radius and ulna. So ulna keeps growing normally, radius lags behind in the growth. So because of the difference in the length, even the inferior radial nerve joint gets subluxating. So there is one more important thing, word I want to mention: SX low presti fracture. SX low presti fracture, where radial head or neck of the fracture is associated with subluxation of radial nerve joint. Okay, yeah, if you can remember, it will be good. Somewhere it will appear as an MCQ question.
Yes, sir.
Open reduction is not required in which fracture? Read carefully. Patella fracture, outer one third of head of radius, condyle of the humerus, olecranon displaced fracture. Very easy because we are
Sir, one
going
third of the fracture head of the radius.
radial outer one third is because it doesn't articulate with the sigmoid notch of the ulna. So it is outer side. In pronation, supination, radial head rotates in the sigmoid notch of the ulna. Outer third doesn't come in contact, even in extreme degrees. So you can excise it. What the question is saying, whether open reduction is required. It's not required. You can excise. If it is displaced, if it is undisplaced, just put a plaster, it will heal. In oblique displaced fracture olecranon, excision and suturing, tension band wiring, elbow is immobilized in the cast, open reduction, external fixation.
Tension band wiring.
Very good, tension band wiring. So now we will come to two important eponymous fracture which are named by an individual. So always you remember Montejan fracture and Galeazzi fracture. There is always confusion. Of course, when you are in internship, you would probably have seen many X-rays. You have finished one or two posting, you will remember. But for students of third, first, who are posted for a first posting in orthopedics, there is confusion. So Montegia and Galeazzi. There is a small mnemonic I have found on the net. Montegia, MU, is Montegia is a ulnar fracture. Galeazzi is a radius fracture. Montegia ulnar fracture A is proximal. Galeazzi Z is distal. So proximal ulnar fracture with radial head subluxation. So it is very easy to remember. Students, please pay attention. Montegia fracture is a ulnar fracture, proximal 1/3 with subluxation of a radial head or superior radioulnar joint subluxation. Opposite to this is Galeazzi fracture, distal third radius fracture, subluxation of inferior radioulnar joint. So both these fracture, the common thing is there is one fracture, there is one joint subluxation. Remember this. There is one fracture and it is a fracture dislocation. It is a fracture dislocation or a fracture subluxation. There should not be any confusion. So at least for today, if you can remember this without any confusion, it will be great. So this MUGR you remember as mugger. Mugger, you know what? Roadside, they mug you to take all your valuables. They are called muggers. Muggers or thieves, robbers. Remember, MUG. Montegia, proximal 1/3 ulnar, and proximal means it has to be superior radioulnar joint. Distal means it should be inferior radioulnar joint. Am I clear?
Yes, sir.
So Montegia fracture is again, remember there are 4 types. Classification is Bado's classification, BADO, Bado's classification. Very, very simple. Don't get confused at all. In type 1, radial head dislocated anteriorly. Type 2, radial head goes posteriorly. Type 3, it is laterally. Type 4 is, so all direction has finished now. So what is remaining? Associated with radius fracture also. So there are 4 types of Montegia. Bado's classification, please remember. See, one radiograph indicative of Montegia is, see the fracture of the ulna. The radial head is subluxated. How will you know? One thing you please remember, if you draw a line in the radius, along the long axis of the radius, in any position, it is called as radio capital line. Please remember this. This is very, very important. Radio capital line means if you draw a line along the long axis of the radius, it has to pass through the capitulum in any position. Radiocapitulum line means a line drawn along the long axis of the radius has to pass through the capitulum. It has to bisect the capitulum in any position of the elbow. Means it is in normal position. But see here, it is going above. The radial head is above the elbow. So there is a subluxation. Monteggia fracture is anybody quick?
Sir, fracture fracture of the proximal one-third of all out with dislocation of
Yes.
the
Okay.
proximal
Which of the
radiology.
following, which of the following is not true about Monteggia fracture dislocation? Fracture of proximal third ulna with dislocation. Extension type is common. Ulna angulates posteriorly in the extension type. Malunion occurs commonly in conserved. Okay, there is this must be except. Hmm?
Yes, sir. Hey, not true.
This,
There is already mentioned, sir, not true.
it is not true. So tell me.
Sir, there is non-union, I think.
No, it is always malunion. It is non. It is not non-union. It unites. So tell
Then,
me.
sir, ulnar angulate posteriorly. That is and
Huh. See, angulation is in direction of the head, whichever. If the head is dislocated posteriorly, the angulation of the ulna is posteriorly.
yes,
Remember
sir.
this. Huh. So then there will be no confusion. If you take two sticks with one hand, same equal sticks, break one, the other one just dislocates. To keep two matchsticks in front of you with opposite direction, break one matchstick and twist it. So there is one matchstick head is a radial head, it subluxated. Posterior subluxation with the posterior angulation. Anterior subluxation is anterior angulation. You can do this trick at home. You can easily remember this. You can remember Bado's classification. You can remember the Monteggia fracture. Okay?
Yes, sir.
Right. Posterior interosseous nerve is injured in.
Sir, that is
Very easy.
yes, sir. Montage, sir.
It is in Monteggia fracture dislocation. So posterior dislocation, Roshan, you remember discussed. Uh, we had discussed that AMRU,
Amru, sir. Yes, sir.
anterior interosseous nerve, median nerve, radial nerve, and ulnar nerve in that order. So posterior dislocation is taken care of. Reversed Monteggia is nothing but a Galeazzi fracture is called as a reverse.
Galeazzi.
Remember that. Supracondylar, of course, there is more commonly ulnar nerve. So
Ulnar.
Monteggia answer. Galeazzi fracture, okay. The slide is not clear. Okay, I wanted to help you in comparing the both Monteggia and Galeazzi. Okay, but anyway, this slide you cannot make out much. Remember ulna again proximally, Monteggia, distal radius, and Galeazzi. Which of the following is not true about Galeazzi fracture? So distal third of radius and dislocation, yes, it is correct.
Yes, sir.
Result fall on outstretched hand, force injury, yes, it is correct.
Correct.
Distal end of ulna dislocates polarly after disruption of DRUJ. Radius is angulated medially and anteriorly.
Sir.
This picture, you will not forget. Look at this. Radius is not angulated medially or anteriorly.
Yes, sir.
This is the
Laterally,
answer.
sir.
Fracture of the proximal forearm cast position. I will explain you this in 1 minute. You try and answer this question. I will explain you what is the rationale behind that. See, fracture of proximal one third of ulna to understand, make you understand better the question. forearm, both bones fracture can be there in proximal 1/3, middle 1/3, and distal 1/3. So, depending upon the fracture, level of the fracture, whether it is proximal, middle, or distal, we have to keep the forearm position, pronation, supination, or mid-prone, above elbow cast. So, what is important is, let us go through this question and then I'll explain the rationale behind. So proximal fracture of proximal radius ulna, 1/3 of proximal, 1/3 of radius ulna. What is the position of the forearm in the cast? Pronated, neutral,
Pronation,
supinated. Huh?
pronation, sir.
No. See, proximally supinator. Supinator is attached to the bicipital tuberosity. Remember this.
Okay,
Bice, supinator, strong supinator is biceps. Remember, biceps is attached to the tuberosity, bicipital tuberosity below the neck of the radius. Biceps, other than elbow flexion, it is a strong supinator. Please remember this. Biceps brachii is a strong supinator. Biceps is attached to the bicipital tuberosity in the radius below the neck. Then comes your pronator teres. Distally, it is pronator quadratus. So, to make things very, very simple, supinators are there in proximal 1/3. Distally, there are pronators. Pronator, strong pronator is pronator quadratus, but all the common flexors are pronators, including your common flexors, which take origin from the lateral medial epicondyle. So, if there is a fracture proximal 1/3, what happens? The biceps, which is a supinator, will keep the proximal part of the forearm in supination. So you have to keep the distal forearm also in supination. If the fracture is in middle 1/3, you have to keep in mid-prone position. If the fracture is in distal 1/3, it has to be kept in pronation. Remember this. Fracture
okay,
of
sir.
both bone forearm at the same level. The position, there is a typo error here. Position of the arm in cluster. This is a mid-prone. Answer is mid-prone.
Okay,
Sorry. So one more. This is what I was talking. You can remember very easily. See, proximal third of radius and ulna, middle 1/3 of radius ulna, and distal 1/3 of radius ulna. Proximal 1/3. This small round thing what you see is bicipital tuberosity where biceps muscle is attached and your supinator is attached. So proximal third, there is a supinator, middle third is a pronator teres, distal third is quadratus, pronator quadratus. Buccal fracture and green stick fracture. This is just an indication. Buccal fracture and green stick fracture are seen in children. Sorry. So green stick fracture, why it is called as a green stick fracture is, you remember any
One side is fracture and another side is remain
yeah,
intact, sir.
is incomplete. You in adults it is incomplete, but in children it is a soft bone. It is an elastic bone. It can bend. It is loss of strength of the bone. You need not see clear cut discontinuity. The definition of fracture is discontinuity of the bone. But in children, green stick fracture means a fracture where the bone has lost the strength. Green stick fracture, one side of the cortex is disrupted, other is intact. So torus fracture, you have to remember this, buccal or torus fracture. If you see here, there is a buckling. What is buckling? under the pressure it buckles, isn't it? Try a soft paper roll or whatever. You press from end to end. It it bulges somewhere in the middle. It buckles under the pressure. It yields to the pressure. That is called as buckle fracture or torus fracture. Fracture is common in metadiaphyseal fracture junction of distal radius. Remember this. Colles fracture, of course, there are a lot of questions on Colles fracture. I will go through few multiple choice questions. Then we'll discuss about Colles fracture. All the following are displacement of Colles fracture except
Lateral displacement. That is medial
ex-
displacement.
yes, it is laterally displaced. Very good. Which of the following is true about the Colles fracture?
It is a extraarticular, sir. Yes.
Very good. There is a choice. Which one is the choice?
Seconds.
No, it is here. It is intra-articular. No, which is what is true? Which is true? It is the question.
Oh, sorry, sir. Sorry.
So associated with dorsal
Dorsal
angulation.
angulation.
Okay. Colles fracture. Is it a radioulnar joint? Fracture line extends into the carpal joint, 2 centimeter proximal to the radiocarpal joint. Distal fragment is ulnar deviated. Distal fragment is volar deviated. Which one is the correct answer?
It is 2 centimeter proximal to the radiocarpal.
Proximal. It is a proximal to radiocarpal means it is an extra-articular joint. All are true about Colles fracture except
Proximal shift, sir. That is dorsal shift.
read carefully. Old age, yes. Dorsal shift or dorsal angulation, yes. Corticocancellous junction, it is 2 centimeter proximal to radiocarpal, yes. Look at this garden space.
No, sir. The dinner for triple.
Yes, I will explain you what is garden spade and what is dinner for little a while after some time. Look at this now. This is malunited Colles or fresh Colles appears like a dinner fork. Here, look at this. Dorsally displaced, dorsally angulated, laterally displaced, laterally angulated, and proximally shifted. It looks like a dinner fork. Look at this. Easily you can remember.
Yes, sir.
What is garden spade? Garden spade is this. It is a, you can think like a reverse dinner fork. Of course, it is not given anywhere. Please remember this. If you keep the dinner fork reverse, it looks like a garden spade. Of course, they have prongs, but garden spade is like this. It's like a spoon. It is like a spoon. Garden spade is like a spoon where it is like this. See, it is volar displaced. Here it is dorsally displaced. Here it is volar displaced. So it is garden spade is in Smith fracture. Just like Montage and Galeazzi, please remember there are many named fracture around the distal end radius. We will go one by one. Colles fracture is dorsally displaced. Smith fracture is volar displaced. So Colles fracture, Smith is but reverse Colles fracture. Reverse Colles fracture. So try to remember only Colles fracture. Then Smith is a reverse of that. One important is Colles fracture and Smith fracture both are Excuse me. Both are extra-articular fracture. So position of wrist in Colles cast.
Pronation and palmar angulation, sir.
Palmar deviation. Yes, very good. This is what I was telling. It is has to be. You have to reverse the position. In you remember the dinner fork? It is dorsally displaced. So opposite of that movement, palmar deviation and ulnar deviation. It is easy to remember. Handshake position.
Yes, sir.
So in exam, if you are not able to remember, make yourself a position of a handshake. Then you will remember. It is palmar deviation, ulnar deviation. All of the following can be complications of malunited Colles fracture. Very easy. Very, very easy.
Sir, rupture of the flexor pollicis lumbus. That is
No. Yes.
extensor pollicis lumbus.
Very good. Very, very good. So what is the anatomy of the extensor pollicis longus? It deviates at the Lister's tubercle. Please remember, it deviates at the Lister's tubercle from medial to lateral. So Lister's tubercle is in distal end of radius. Malunited because of attrition, because of frequent rubbing, friction, it can get ruptured. Here you have to read carefully. Here they have given flexor pollicis longus. If nothing happens to flexor pollicis longus. Lady with a Colles fracture healed, but after a few days she developed pain and swelling over the wrist and forearm. Red hot and shiny, and on X-ray, patchy osteoporosis is seen.
Sudex dystrophy.
Very good. Sudex dystrophy is a old terminology. Nowadays we call it as reflex sympathetic dystrophy, RSD. Please remember this. Also called as CRPS. Can anybody tell me what is CRPS? Complex regional pain syndrome. So, Sudex dystrophy, RSD is reflex sympathetic dystrophy, CRPS is complex regional pain syndrome. Remember this. So, there are two types. Type 1 is due to nerve injury. CRPS is also called as causalgia. CRPS 2 is called as causalgia. Remember this. There are two types, type 1 and type 2. You remember in any amputation, there is a nerve injury. In any fracture, compound fracture, if there is a nerve which is impinged, it can cause severe pain. Even though our fracture has healed, but there is continuous pain. That is type of a causalgia. It is also called as complex regional pain syndrome.
Yes, sir. Burning pain and patchy osteoporosis.
Yes. Type 1, it is a type 1 which is a fracture complication. Type 2 is a nerve injury. Remember this.
Yes, sir.
Management of Smith fracture. Smith fracture I had mentioned. It is an extra-articular fracture. It is a reverse Colles fracture. So what is the management? Open reduction fixation, plaster cast, and forearm in pronation, close reduction with below elbow cast, above
Above the
elbow.
elbow cast supination.
Huh?
Above the elbow and supination, sir.
Yes, it is opposite to the collis,
Uh,
isn't it?
police fracture.
Yeah, all are injuries of lower end radius except, please remember this, Smith fracture, Collis fracture, nightstick fracture, Barton's fracture.
Yes. Sir, nightstick.
Yes, nightstick fracture is middle one third of ulna fracture. Imagine if somebody is hitting you, you raise your forearm. You raise your forearm. Somebody is hitting you with a stick, especially in violent protest or in your self defense. You raise your forearm. So the ulna is the what first gets fractured. Nightstick fracture is isolated middle one third of fracture ulna, not associated with any proximal radial head subluxation. If it is subluxation, it becomes Montegian. So I wanted to tell you about distal end radius fracture. There are so many named fracture. There is no much of confusion. You please remember. Common distal radius fractures. Extraarticular, these two. It is extraarticular. Collis is dorsal displacement. Smith is volar displacement. Remember Collis, very easy. Collis malunion causes dinner fork. Smith
Deeper.
causes spade. Okay. These two are extraarticular fracture. So when you try to remember one, the opposite will be the other fracture. So always try to remember one. Then you will not get confused. So intraarticular is dorsal Barton. Barton is intraarticular fracture. Barton is intraarticular fracture. So it can be a dorsal Barton or a volar Barton. Okay, look at this. So what is the difference between intraarticular fracture is there is a look at this X-ray. There is a part of the distal end radius fractured and the joint is subluxated. Please remember this. This is not volar subluxation. This is not entire radius and radiocapital joint is not displaced. It is subluxation. This part of the radiocarpal joint is subluxated. Okay, there is a intraarticular fracture. The fracture is extending into the distal end articular surface and subluxated. So Barton's fracture is fracture subluxation or fracture dislocation. Collis and Smith are extraarticular. There is no subluxation or dislocation of the radiocarpal joint. Schoffer fracture. You remember this. Chauffeur is what? A driver. So a radial styloid. This is a radial styloid fracture. Radial styloid fracture is also called as a Chauffeur fracture. Why it is called as a Chauffeur fracture is in olden days there was no starter. You see these shutters being raised or lowered by a lever, isn't it? Anybody
Yes.
has seen the shutter is being raised or lowered by a lever, long lever. This lever used in jack also. This suddenly this lever, if you leave it, it hits back with a force. That's why it was called as a chauffeur fracture. In the olden days, chauffeurs used to start the vehicle with a lever which used for a jack or which use it for a raising the rolling shutters. So that's how the name of a Schoffer fracture is radial styloid fracture. We have to go to carpal bone fracture. I will end the class now so that we can discuss in detail. Okay? Roshan, you are still there?
Yes, sir.
Okay. Any doubts?
Sir, proximal radioulnar fracture, that is supination, and sorry, distal is supination, sir, and proximal is pronation, sir.
No, remember the muscles attached. Proximally, what muscle is attached? Biceps muscle and a
Yes, sir.
supinator muscle. So it acts in a supination, isn't it?
Okay, sir.
Distally, you remember pronator quadratus.
हाँ sir.
I'll, I will show you that picture so you will easily remember. Look at this picture. See, here your biceps, the main flexor of the elbow, what you see, you do exercise and you see biceps, no? Where it is
Yes,
attached?
sir.
It is attached bicipital head, tuberosity. It is medial side. So that is the strongest supinator of the forearm. Next is your supinator muscle. Pronator teres is attached to the middle third. Pronator quadratus is in the distal one third. So supinator in proximally, distally pronator. Okay. So proximal fractures you keep in supination, distal fracture you keep in pronation. Middle third you easy. It has to be middle is mid prone position.
Okay, sir.
You have to find mnemonic, whatever. But best would be remember the attachment of the muscle. Proximally supinator muscle is attached, isn't it? Everybody knows that.
Yes,
Biceps
sir.
is the strongest supinator. So remember that you are the pronator quadratus. Everybody remembers, isn't it? Pronator quadratus is a quadrangle shaped pronator in the distal part of the forearm. So there is nothing. Don't try to make too many mnemonics. Also, you'll remember the mnemonic, but you forget the expansion of the mnemonic. Sometimes you try to be reasonable by doing a logical reasoning.
Okay, sir.
Okay. Yes. Anybody?
Thank you, sir.
Yeah. Thank you, Roshan.